We developed the care model or the care structure for CSA, and we've been teaching this for a long time with great success. We deliberately wanted something simple because I've seen a lot of candidates struggle that have overcomplicated. I've seen people with 15-point checklists. No wonder you're missing things. You're thinking about more than one thing every minute as to, I've got to do this, I've got to do that. No wonder you miss what the patient says and you miss the cues. It gets in the way. So the care model is really simple. It's just got 4 things in it. And the reason we call it the care model, number one, is the mnemonic, C-A-R-E, but also what makes a great consultation in CSA is the same thing that makes a great consultation in real life, the same things I try to do when I'm in clinic. And that is that, number one, you have to care about your patient. Don't treat this like a transaction. Don't treat this like a role play. I know it is a role play in the exam, but treat it like a real patient in real life and someone that you really, you care about doing a good job and you care about getting to the bottom of their problems so you can help your patient. Number two, you have to provide them with a high standard of care. To do that, you have to know your stuff. You have to know which questions to ask. You have to manage your time, because if you take too long and you run out of time, you're not going to be able to give them a good standard of care, because you're going to run out of time and miss things perhaps, or rush things. Okay, so yes, you have to be caring, but you have to give a good standard of care by asking the right questions. And once you've worked out what it is, by being so well read that you know what to do with it according to the current guidelines. So you've got a good knowledge base as well. So these are 2 things that make a great consultation in real life. They make a great consultation in the CSA. So let's look at the mnemonic. So the C in care is for connecting. This is really the first minute or so of each consultation. You want to start each consultation with a polite professional introduction. Okay, you want to start with a couple of open questions and try to keep an open mind. Remember, this is general practice. Any case can actually be about anything. So for example, just because when you looked at the notes before the patient knocked on the door, that 2 minutes of reading, just because they're known to have diabetes and they're on a couple of diabetic medications, it doesn't mean that they've come to see you today about diabetes. They may have done, okay? But can you see, someone with diabetes could wake up with a really bad headache and they're having a subarachnoid hemorrhage. Or someone with diabetes could be starting to get chest pains and they're developing angina. Someone with diabetes could come to see you about something totally unrelated. They have got an STI, okay? Or they've got a urinary tract infection, or whatever it is. And if you make an assumption that this case is about this and for example, label the case, you might completely miss the point. Whereas if you start with, a couple of open questions, how can I help you today? What's brought you into clinic today? What would you like to discuss today? Listen to what they have to say, and then maybe, another open question just to explore a little bit more. And then most of that first minute, you listen. Okay, the first minute we sometimes call the golden minute. It's a golden opportunity to find out what is it that the patient wants to talk about first. Okay. So whatever they say here, if you get started with that, you'll be off to a good start. Okay. But it's also, you're going to listen and mainly let them speak. So there's a lot of silence from your part in that first minute, and silence is golden, right? So that's why it's the golden minute. So that's the first minute. It's connecting. Polite professional introduction, open with a couple of open questions, mostly listen. A is for assess. This is the bulk of your data gathering. Now you want to get focused. Don't be scared to ask specific closed questions now. There's nothing wrong with closed questions. As a doctor, if you want to separate someone who tells you in the connecting phase that they've got a headache and they've had it for a while and they're quite worried about it. Now, you've asked a couple of open questions. If you keep asking vague questions like, is there anything else, or tell me more, what you'll find in CSA is that you won't get much information from the simulators. They're trained not to just give everything, that you need to ask specific relevant questions to get specific symptoms, for example. What you need to do is be focused, be structured, and get to the point. And it's okay to ask some specific close questions. If I want to separate subarachnoid hemorrhage from a cluster headache, from a migraine, from a tension headache, I need to know, for example, if it came on suddenly or if it's gradual, if it's there all the time or if it comes and goes, if it's on one side or if it's a tension band around the whole head, if there's specific things that set it off, if they feel sick with it, if they've actually vomited, if they've got pressure behind the eyes, if it gets worse if they bend over. You can see, I want to know specifics, right? Because that's how I'm going to work out if I'm going to give high standard of care and to work out what it is. So you're going to explore the symptoms, explore risk factors. Don't forget to be safe. Exclude any relevant red flags. Okay, and about halfway, so about 5 minutes, is a good time to get the bulk of your history done. And you want to start thinking now, is there a relevant examination for this person? Because if there is, shortly after 5 minutes, you want to move on to it. Why? If you need to examine them, that's going to take you another couple of minutes. that doesn't leave much time for diagnosis and management. You know, someone that takes such a long history that they're still taking a history at 7.5, 8 minutes, if they then need to examine that patient, they will either be examining or just finish their examination when the buzzer sounds. They're going to get a clear fail for management automatically, even though they might know it, just because they won't get there. Okay, so you want to start thinking about examination about 5 minutes or just after. And if there is one, move on to it. Now, R is for review. So you've taken your history, you've examined or you've thought about examination, and take a second for yourself now to review what you've found, because patients don't give us everything in one go. You know from the records they had this, then you asked about this symptom that they'd mentioned, you explored it, then you found out they got this risk factor, then you put that together with this examination finding, and it will click. Taking those few seconds to pause for yourself, to put it all together, it'll click. Then you can confidently review with the patient the diagnosis. This is what's going on. Be confident, own it, okay? And then you're going to move on to management. Manage the main problem first. Now, sometimes there'll be more than one option, so you might be discussing them with the patient, coming up with a plan together. Manage the main problem first. Then think, are there any other big risks that need to be dealt with or discussed? Then you want to think about your follow-up. When would you routinely want to see them, for this particular condition? What would be the norm? Or if you're going to send them into hospital, you need to be clear. Is it a 2-week referral? Is it today? Is it within 24 hours, within 48 hours? Is it, a referral that they might be seen in a few months? So that's your review phase, okay? That's most of your management marks. And then E is for ending, last minute or so. Think about safety netting. So you've said for this patient that you look to see them again in 4 weeks, for example. Are there certain things that the patient should be aware of, and if they happen, you'd like to see them quicker? If this or this happens, please give us a call. We'd like to see you sooner. If this happens, you should call an ambulance. You need to be seen straight away. Okay. And then if there's anything extra, anything else, you need to do some secondary things or ask them to come back for something that you can't deal with today. That's a secondary issue or a minor problem. Leave that to the end, because if you've dealt with all of those things and got to safety netting and you've run out of time with extras, you're going to be fine. Whereas sometimes what a candidate will do is they deal with the side issue first, but they haven't dealt with the main problem. Let me give an example. If you've got someone having a subarachnoid, and as part of your history in your assessment phase, you found out that they're a smoker, if you go off on the side issues, start talking about them giving up smoking when they haven't come to talk about smoking today, they're worried about this really severe headache, they've never had anything so bad like that before. Can see if you focus on the extras, the side issues of smoking, and you run out of time and don't admit them for their subarachnoid, what's the point? Yes, this patient might have given up smoking, but it's because they're dead. It's not a great standard of care, is it? You're going to fail or clear fail your management because you haven't dealt with the main problem. The side issue hasn't helped you at all. Whereas, can you see, in that particular scenario, if you'd worked out it was a subarachnoid, told them that, i.e. the diagnosis, explained they need to be admitted today. Now, if you don't talk about smoking cessation today, it makes no difference. You're still going to have got a pass or a clear pass for your management. Why? Because that probably isn't the most important thing today. Do you see? Leave extras to the end, because if you run out of time for them, it's not important. Whereas if you deal with an extra and run out of time to deal with the main problem, you'll fail your management, okay? Or clear fail your management. So that's the care structure. More than anything, it's a way to manage time. It's a skeleton. You're going to flesh out this skeleton with specific questions that are going to be different for every case. That's where your knowledge and your reading comes in, okay? And also with your own style. There's not just one way to communicate, okay? You've all got your own style, okay? So that's the care model. The first minute, polite introduction, open with open questions, keep an open mind, a lot of listening. A is for assess. Now focus, structured history. You want to explore the symptoms, the risks. Don't forget the red flags. Start thinking about examination about halfway. R is for review. Take a few seconds to put it all together, then review with the patient the diagnosis and the management. E is for ending. Safety net, anything else, leave it to the end. That's the care structure.